the education unit for residency program in the National Eye Center for consistently organizing this webinar lecture. How are you all doing with the COVID program? Please try and keep safe and stay at home. We will be looking at diagnosing infective corneal ulcer. And we want to look at it in this format. Corneal ulcer, also known as keratitis, is an inflammatory condition, more seriously, infective condition of the cornea resulting in disruption of either its epithelium and stroma and beyond. In a layman's term, the infective corneal ulcers can also be regarded as a sore in the cornea. A wide variety of causes have been attributed to this condition, ranging from infective to physical and chemical bonds, drying and exposure keratitis, contact lens use, and misuse of other chemicals can also result in corneal ulceration. Infective keratitis is an ocular emergency that requires prompt and appropriate management. Without adequate treatment, corneal infection leads to blindness. If the ulcer goes beyond the Bowman's and stroma layer, eventually it heals as a scar. The natural cause of the disease is such that if the infection is cupped, the healing will go, without sequelae. Vision and other related things will be normalized. But where there is a penetration of the Bowman's and the stroma, healing occurs with scar, and the subsequent sequelae, depending on where it affects, could range from visual impairment, if it's in the visual axis, to astigmatism. When the infection is not cupped, a lot of other devastating consequences can result, including perforation, uveitis, endophthalmitis, pseudo-cornea, and staphyloma. All these are consequences of infection. Typically, this is a scar cornea. On this side, you can see it's affecting the central vision, and also on this other eye, we can see vascularization all around it. This is a descementocele where there is a bulge as a result of the intraocular pressure over the defects of the epithelium, Bowman's, and stroma. There are complications arising from ulceration of the cornea. This is an adherent glaucoma. We could see the iris here impinging, on the stroma. We will want to also see some other complications. This is pseudo-cornea. You can see, the whole cornea has melted, and what is just remaining is just the descent that is just hovering, and with the internal structures, the uvea, perching upon the cornea. We also have, pseudo-cornea that can come in different degree of thickness depending on the fibrosis that occurs following the injury. Apart from pseudo-cornea, staphylomas can also develop, thereby resulting in a bulge of the entire globe, and it can be very devastating, cosmetically and otherwise. Signs of healing ulcers, which we need to just reiterate quickly, is the fact that when ulcers begin to heal, we should see evidence of arrest of the various symptoms and regression also, pain, redness, discharge, and the likes. For ulcers that have exudates and infiltrates, there will be a reduction. The edema also around the ulcer will also begin to reduce. Red lines are usually seen also, and these pave way for infiltration of blood vessels. The cornea naturally is an avascular structure. The burden of the disease is still with us, and generally, the prevalence of corneal blindness secondary to microbial keratitis is unknown generally. However, we do know that a lot of studies have showed some form of reports. From Nepal, for example, the National Blindness Survey gave a figure of 7.9 as a result of corneal blindness. In India, the prevalence has been recorded in some studies as 0.66%. In Nigeria here, Southwest Nigeria, a report from a study gave a figure of 0.2 to 0.9%. However, our National Blindness Survey gave us a figure of 13.7%. The reasons for corneal blindness cannot be emphasized. It has been observed that a lot of attention has been given to cataract and reduction of the burden of cataract. So this sometimes can create an imbalance and will result in the perpetual, rise of cornea-related blindness. Also, we know that we have limited cornea specialists. This also, makes it that whenever we have cornea diseases, the best of opinion may not be readily available. Late referrals have also been things we see even in most of our centers, in tertiary centers, where cornea disease, cornea ulcers are not referred as early as possible. Poorly developed laboratory facilities that are supposed to be adjuncts in the diagnosis and treatment of cornea ulcers are also a problem, particularly in the developing world. We also have abuses and misuse of antibiotics and steroids. This sometimes, have make a toll upon the burden of cornea-related blindness from ulcers. The use of harmful traditional eye medication is still with us, and it is something that education and continuous, education will really be needful to curb it. Treating infectious corneal ulcers can be a daunting task, particularly for clinicians. But conquering these challenges can be rewarding for practitioners as well as patients. This is a saying, by error. Also, according to Asharif, maximizing the clearance, the chances of complete recovery requires first pinpointing the etiology. An ulcer that you have not really pinpointed the etiology, the cause, you are not rightly going to treat it properly and have the best of outcome from it. Diagnosing infective corneal ulcer in this part of the world is still a challenge. And not only in this part of the world, even globally, in most of the well-equipped centers that have state-of-the-art facilities, diagnosing infective corneal ulcers can be a challenge, where several etiology will sometimes mingle up and make the diagnosis not very single-handed. Vital key to diagnosing is still a gold standard of protocol that we should continue to aspire and then work with. And in this lecture today, we are going to be reiterating on the need for the gold standard protocol for diagnosing infective corneal ulcers. Where there are difficulties and challenges in having an equipped laboratory and the state-of-the-art facilities for diagnosis, clinical experience of the clinician will be very needful. And we see that play a lot, particularly in developing countries. We are likely going to be looking at important issues, significant gray areas that comes with diagnosis of infective corneal ulcers, particularly when there is just a marginal improvement in the ulcer that you are managing. Also, it becomes more puzzling when the ulcer begins to worsen despite medications or any form of management have been instituted. Once you have these two important challenges, then there will be a serious need to reevaluate. So the timing as to when to reevaluate may be put forth and dictated by the level of improvement and how the ulcer have been responding to the management that have been instituted. When to culture and the best use tool for culture is also another important gray area, particularly when improvements are just marginal or when in fact the ulcer is worsening. When microscopy and culture results are negative, which many a times we do encounter, these are important questioning gray areas. And what we need to do at such times are things that we'll be looking into in this lecture. When to refer and seek second opinion. Just like I've said before, we have several times seen ulcers referred lately. And one would have thought that such ulcers should have been referred much earlier, or at least a second opinion sought, particularly when the treatment regime does not seem to be improving the ulcer condition. Generally, it has been considered that when an ulcer is larger than 2 millimeters in diameter, you should consider referral. When the ulcer is directly located on the visual axis, you should also consider referral. When you begin to have stromal melting, these are indications that your management needs to be reevaluated and the patient needs to be aggressively treated. So a consideration for referral, it's very eminent. Wherever you have anterior chamber inflammatory reactions, it's considered an indication for a referral so that a second opinion and a proper expertise advice can be given for such ulcer. For any form of scleral involvement, that ulcer needs to be referred to a specialist where available. In fact, when you have scleral involvement, sometimes you even need an immunologist to co-manage with a cornea specialist. Diagnosis certainly is key to effective treatment, excellent outcome, which is most desirable by the patient and also gives the clinician a satisfaction. And so this very topic appears to be very pertinent and should be practical because our day-to-day clinical practice as ophthalmologists or clinicians makes us come in contact with patients with corneal ulcers. What we discover as challenges, particularly in this part of the world, in the management of corneal ulcers, when patients present late or when there are poor history, with the ulcer presentation, all these things make management become more difficult. We should also be aware that many times we will have mixed infections, and this causes a challenge in the management of such ulcers. Comorbidities are things that we need to be aware of, and we should tend to seek so that we evaluate the whole patient. A diabetic patient that is immunocompromised, a patient with autoimmune, disease. All these are, systemic problems that affect the management of corneal ulcers, particularly infective corneal ulcers, and the proper evaluation needs to be done. We could have a small anterior stromal infiltrate with minimal or no anterior chamber reaction. This, could go with some form of medication and management. But when you begin to see the ulcer, get larger, wider, deeper into the deep stromal layer, when there are a lot of discharges all around it, you know that you are in for a more serious matter that needs to be properly evaluated for proper treatment. At this level, complications such as corneal opacities may be very inevitable. Of course, when you have a very extensive, widespread necrotic ulcer with deep stromal and severe anterior chamber inflammations, at this point in time, the globe is at risk of being lost, and always demands proper re-evaluation, proper diagnosis, so that the right treatment can be ensued. We will now want to look at some typical presentations which are commonly encountered in our practices. Generally, it is said that for gram-positive bacterial ulcers, the uninvolved portion of the cornea appear clear without edema or infiltrates. We will see this typically. There's sharp demarcation between the unaffected cornea area and then the disease cornea area. Also, for most gram-positive bacterial ulcers, marked lead edema and chemosis are characteristics. So these are important landmarks that we should look for while examining such patients. For staphylococcal and streptococcal species leading to ulcerations, it has been generally known and observed that the ulcers are usually round or oval. They usually have a well circumscribed area, and they are well limited to either the central or the mid periphery of the cornea. Stroma infiltration appear yellowish to white, and the infiltrate present under the base of the ulcer. In advanced cases, stromal, the deep stromal beds show some radiations in the ulcer area. These are typical of staphylococcal, corneal ulcers with mild to moderate anterior chamber reaction. The conjunctiva is highly hyperemic in this patient. Another common bacteria that we encounter causing corneal ulcers is the pneumococcal bacteria. It is recorded in some studies that as high as 55% of patients with chronic dacrocystitis are presented with pneumococcal corneal ulcers. But generally, trauma is also a very non-causative factor or risk factor for pneumococcal ulcers. In these ulcers, one of the distinguishing characteristics is hemorrhagic hypopium. We also have discovered frequently that the corneas have associated degenerations, particularly of the epithelium, and they are also found around corneal scars. So these are risk factors for pneumococcal ulcers. Pneumococcal ulcers generally have creeping edges, and their infiltrates are usually dense in character. These are typical of pneumococcal ulcerations. You can see the hypopium at a very high level, the creeping characteristics, of the ulcer. It's not completely round or oval the way we saw in the staphylococcal ulcer. Another organism that is commonly encountered in corneal ulcers is Pseudomonas. For Pseudomonas, a very short history is characteristics. And we also have some other risk factors for it, either the use of contact lenses. You will have those distinguishing features in your history. But in conditions related to Pseudomonas, the signs and symptoms are usually more severe and very acute. The whole cornea easily assumed a ground glass appearance, and this is a very good distinguishing feature for Pseudomonas ulcer. It is also usually associated with mucopurulent, blue to greenish discharge, and usually, it is found when the ulcer is still in an untreated condition. It may also develop ring ulcers without epithelial defects. So these are very aggressive conjunctival reactions following the ulceration. You can see how wide the ulceration is. You can see the anterior chamber reaction with hypopium. This is also almost taking more than 2/3 of the entire cornea. We also see a very high level of hypopium, and of course the conjunctival reactions over there. Hypopium is almost always present in most of the Pseudomonas ulceration, particularly as they advance more. Away from bacteria, let us consider fungal keratitis. For fungal keratitis, history is very important and paramount for us to look at. It is commoner, particularly in the agro-allied areas where you have farmers. So by the time you have a farmer coming in, and that is a significant pointer. Where there is trauma with vegetative materials, these are also very important information in the history that will make us have a high index of suspicion for fungal keratitis. So the risk factors and distinctive signs are things that we're supposed to watch out. Principal risk factors also include contact lens wear. And most of the time, these are found in the very healthy individuals with protracted epithelial ulcerations. They also are very important risk factors for the development of fungal keratitis. Where there has been use of steroids, topical steroids, it is known to enhance replication of fungal organisms. And particularly Candida is very common where you have mixed microbial keratitis. For filamentous fungal species, the ulceration is characteristically made up of fine feathery palisades material. And usually the overlying epithelium may be intact, or depending on how deeply the ulceration have gone, it may have affected the surface, creating some granular elevations and irregular contours in the corneal surface. These are the fine crepes and extensions of the fungal organism. All these also are extensions, and satellite lesions are also characteristics of fungal keratitis. These are typical of satellite lesions, also typical in fungal keratitis. For Candida, it typically produces epithelial ulceration. The ulceration we see in Candida keratitis is usually worse off, unlike the filamentous keratitis. Filamentous fungi. Focal necrotizing stroma infiltrations and inflammations are also very typical in Candida infections. There may be moderate cellular infiltration, and edema in the adjacent stroma may also be minimal or mild. These are typical of Candida infection affectations. Here we can see the affectation of the stroma deep down. Also in this, we could see a lot of discharge around, and the edema is spreading far away from the dense area of infiltration. Whenever we are faced with diagnosing corneal ulcers, infiltrates are very key, and they present as areas of aggregates of cells. This must be distinguished from abscesses. In abscesses, the epitheliums are usually intact over them, depending on the stage of the disease. And this should be properly observed. Away from fungal keratitis, we will want to look at herpes. This is another common, causative organism or agent that leads to corneal ulceration. For herpes, the diagnosis of herpes most of the time is mainly made clinically. About 90% of herpes ulcerations can be done clinically. Only a few may require further investigations to be able to label the diseased entity. Here we can see the filamentous lesions with branches and buds. These are typical of herpes. Here also we can see it's expanding, and it's becoming more typical, and by this there's a coalition of the dendrites, the dendritic ulcers, and now forming a geographic ulcer. So these are typical, but most of the time the patient may come at different stages. So a typical history of either past infections that gives us an indication of herpes are usually very characteristic. Then for patients that have been suffering recurrent herpes keratitis, one of the characteristic features is the cornea loses its sensation because of the affectation of the nerves. So these are typical findings that we should look for clinically in patients presenting with these forms of ulcers. When patients present atypically with large central ulcers, your guess will be as good as mine in terms of the causative agent. Also, when infiltrates are irregular, these are atypical presentations that gives a more, puzzling questions as to the organisms that is causing it, or the causative agent. Feathery margins have also been seen in some other disease conditions other than fungi. Pseudomonas, can also present with that. Cantamoeba can also present with that. So whenever you see some of these features, they may have to create a puzzling question as to the causative agent. When you have satellite lesions, several factors can be responsible. In an eye with multiple trauma, areas of trauma, and focal of infection, it will appear as if it is a satellite lesion. So all these are factors that we need to reevaluate and reconsider for proper diagnosis. Perineural infiltrates and amorphous shape infiltrates are also very characteristic that could go into several other causative agents. This is a picture of a patient with Norcadia keratitis. Like we said, the shape, the density of the infiltrates, the extended lesions, all these could create a diagnostic puzzle and will lead to us asking more definite questions as to how and what is the causative agent for this ulceration. This is also typical of microbial keratitis. This patient was diagnosed to have Pseudomonas aeruginosa. But again, when we look at this typical presentation, it could also go for Cantamoeba. It could go for a lot of other factors, particularly if the patient has some other comorbidity like diabetes. A lot of etiology could be profiled, and that is why diagnosing infective keratitis is very important. And from the scenario we see in developing world, like I said initially, is the fact that late presentation has been the typical thing that we have seen in terms of presentation of corneal ulcers. History and clinical pictures sometimes are very weird, and these are supposed to be vital for us to be able to adequately diagnose and give a clinical inference as to the ulcer that we are handling. So with this, it creates a lot of tasks to the clinician. And what we see many a times, particularly in the developing world, where facilities for laboratory services and other tools for diagnosis are limited, the use of empirical treatment has been a major form of practice. However, we should begin to shift from that paradigm such that we give more emphasis to diagnosing every ulcer that presents to our clinics. There are lots of challenges that keep coming on, particularly as the ulcer either improves marginally or worsens. The question of culture, microscopy, and other ancillary investigations becomes very pertinent. And that is where we are going to the core of the matter of the lecture today, diagnosing infective corneal ulcers. We have tried to give some typical presentations of some ulcers before now. But like we said, clinical assessment alone cannot 100% help us diagnose corneal ulcers. Presentations can be very varied, can be very deceptive also. This is a case of an early stage of epithelial acanthamoeba, and this resembles epithelial dendritic herpes simplex keratitis. So with these lesions, your guess, will be as good as mine. But detailed investigation for diagnosis is very pertinent in a condition like this. This also is a dendritic epithelial herpes simplex keratitis, and in this patient, diagnosis showed that it was acanthamoeba, and you can see also different resemblance of herpes simplex keratitis. These are ring form ulcers. Several causes of ring form ulcers, including Pseudomonas. But in this particular patient, you can see acanthamoeba presenting typical ring, ulcers. Look at the extent of the reaction, anterior segment, anterior chamber reactions in these patients. Turns out to be acanthamoeba with deep anterior chamber reactions. This is another acanthamoeba with anterior chamber reaction. So invariably, because of the varied presentations of corneal ulcers, clinical diagnosis is not adequate. We need to go further, and in doing that, we need to still reiterate on the gold standard for diagnosis of infective corneal ulcers. There's always a need to label every infective ulcers to its causative agent. And it is only then that we can rightly appropriate the right treatment modality that will be able to curb that infection. The protocol for microbiology, culture and sensitivity is still the gold standard. And we are going to be looking at a few of those processes in the form of this, in the course of this lecture. Like we said, because of the lack of laboratory facilities and adequate tools, empirical treatment has been the major form of practice. But the international best practices is such that we should move away from empirical treatment, and we should have little room, for it. Corneal scraping is very important. and is an important step in the diagnosis of infective corneal ulcers. There are several things that can be done within, the immediate and then the later part of the treatment. In the immediate, microscopy are being considered at the gold standard, direct microscopy. And there are several processes that have been well outlined for diagnosis of infective corneal ulcers. The most popular and the old age long process is the gram staining. We also have the potassium hydroxide wet mount. We have the methylene blue staining, calcophore white, Giemsa stain, and several, of those. But for short of time, we will just be taking at one or two of such techniques, which should be readily available in any hospital that offers services for corneal ulcer management. In scraping, there are a lot of factors that could aid in you having a more reliable and positive result. Factors contributing to the rate of positivity includes, when you have a larger ulcer, the size of the ulcer sometimes and many a times, is a factor in the level of positivity of the result that you may get from such scraping. It has been well documented that when an ulcer is greater than 2 millimeters in diameter, it provides a higher rate for positivity. The scraping technique is also very important. When we scrape the right area where we are likely going to have a better result, then the positivity will be higher than when we just do a blind scraping, not taking into cognizance the edges of the ulcer. Gives a lot of positive result in the bacterial situation. It is known that the infiltrates, they are more of dead tissues, leukocyte tissues that are more aggregated in those areas. So you are likely going to have a less positive result, particularly when you don't take adequate material. The amount of material scraped, therefore, is involved. We should be able to take enough specimens that will give us a higher chance of getting a positive result. Then the microscopic observation, these are technical, better for people that are well trained for such proceedings. But however, we are supposed to be also aware of the fact that we can and we should also do our own microscopy as clinicians. For gram stain, we are supposed to remind ourselves of the basic principles. Usually, the slides have the tissues, have the scraped material mounted on it, and it is heat fixed, and then crystal violet is applied, and thereafter it is washed, and then application of iodine is made. That gives the staining, and thereafter it is washed again using alcohol-based solution, and finally saffron is now used to fix, and then the slide is now observed under the microscope. Generally, for gram-positive organisms, it gives a dark purple appearance, And for gram-negative organisms, it gives a pale to dark red appearance. Dark purple appearance can also be seen with yeast, but of course they are more slender, longer than the bacteria, except for Norcadia, species. The epithelium also is stained pale red, as you observe. These are typical of gram-positive cocci. These are typical of gram-negative cocci. These are typical of gram-positive rod. You can see they are longer. These are typical of gram-negative rods from the length of the cells. Still on staining microscopy, away from gram staining, we will also consider KOH, that is potassium hydroxide wet mount. For potassium hydroxide wet mount, usually 2 slides also are required, and the first is viewed with just saline, and then the second one is viewed using the staining with potassium hydroxide. Potassium hydroxide dissolves the cell membranes, and then it enables the core cell units to be seen. These are typical of fungi. You can see the filamentous, nature. This is an enhanced, view at a higher magnification, showing the filaments. These are also, views of the filaments. Some are branched, and some are just straight on. KOH has also been known to be very effective in diagnosing Candida, apart from fungi. And the Candida cysts are usually seen, particularly at higher magnification. This is yet another magnification of Candida cysts, and at a higher magnification, the details of the cyst is becoming more prominent. Apart from Candida, KOH are also very sensitive in identification of Norcadia bacteria. And you can see the lengthy nature of the organism. This appears to be a mount, a wet mount showing mixed infection, where we can see fungi on the higher magnification here. Evidence of Norcadia was also seen. Usually Norcadia are smaller size than the fungi hyphae. Now, the degree of sensitivity of the various microscopy we do have been well documented. Gram stains certainly are better for bacteria, and the gram stain also have different degree of sensitivity for different pathogens. For gram-positive organisms, it is said to have a higher, degree of sensitivity. Also for bacteria like the gram-positive rods, Norcadia, you discover that they have lower sensitivity. So when there is a high index of suspicion, we should know what tests we really want to require and request. KOH mount are better off for fungi. In fact, the degree of sensitivity is almost 99.3% in the study that was done, trying to compare it with the diagnosis of Norcadia cantamoeba using KOH and Gram-Stain. So it has been found that it is more sensitive to both, to fungi, Norcadia, and also cantamoeba, giving a better result than Gram-Stain. In another study that was done from Egypt, methylene blue was found to be very effective in the diagnosis of fungi. So that is also an alternative where KOH is not readily available as a test tool. Positive rates for calcium white, methylene blue, and KOH were also considered, and it is found that calcium has a higher sensitivity rate for diagnosis of fungi than methylene blue and KOH. So all these are studies that have relevance in terms of what may be available at any diagnostic center in our settings. Giemsa stain, when it is followed by calcium white, is seen to enhance the diagnosis for fungal keratitis. So that has also been well documented. Away from microscopy, specimens are taken for microscopy, and basically we have nutrient agar, we have chocolate agar, we have blood agar, we have specimen for viral investigations. They are all taken in addition to slides. These are important materials that we need when we want to consider scraping all in one sitting. The separate agar are usually better off for fungi culture, while teoglycolate and blood agar are good enough for aerobes, but teoglycolate broths are better off for anaerobes when we want to consider anaerobes. We also do not generally have materials for culture of viral organisms and chlamydia, but in laboratories that are well equipped for such, then materials are also taken for it. We also take materials for any other form of culture that may not be readily available. In a typical corneal ulcer tray for culture, we're supposed to have a marker by which we mark the micro slides for the direct microscopy. We also have a use of anesthetic agents, and most of the time we prefer a preservative-free anesthetic agent, either tetracaine or propcaine, 0.05%. We also have lighters and a lamp so as to sterilize the instrument we use in scraping. And that is particularly where we use a cameral scraping tool. But in some centers where this is scarce, the use of 27 gauge needle has been known to suffice in that regard. These are chocolate agars, blood agar, and then the nutrient agar. So these are basic tools or basic materials that should be in any corneal tray. For the cultural material, there are some that are not readily available, like the patient's medium. It has been found to be very effective for acanthamoeba. Apart from microscopy and culture, we have other ancillary tests, general tests, systemic tests that need to be carried out depending on our index of suspicion for the organisms. For patients that have systemic involvement, we may want to do a full blood count, total and differential. A patient that is anemic certainly have more chance for ulceration from from the status. Also, by the time we do a differential, the differential counts will also give us an indication whether we have absolute leukocytosis or we have lymphocytosis. It will give us an indication how chronic or how acute that situation has been. The ESR, erythrocyte segmentation rate, is also an important investigation that should be done generally, particularly for a patient that is debilitatingly sick. Diabetes is very common, and we know that ulcers in diabetic patients take an unusual toll. So patients should generally be screened to rule out diabetes. Their immune status also needs to be considered, and retroviral screening, is done. For viral keratitis, particularly those presenting in an atypical form, the usual dendritic ulcers or geographic ulcers are not typically, seen clinically. There are needs for further investigation. Polymerase chain reaction technique has been found to be very effective in diagnosing herpes simplex, keratitis. In fact, a lot of development are on now in not just limiting the diagnosis of infective keratitis, of viral origin to polymerase chain reaction, but it has gone beyond that, and virtually all forms of infective keratitis can be typed and labeled, by polymerase chain reaction technique. Immunofluorescent staining is also an important technique by which organisms are labeled. We also have anterior segment ultrasonography, OCT, that's the optical coherent topography. This has also been shown in the recent time as very useful tool in diagnosis of infective corneal ulcers, particularly of acanthamoeba, and also some form of fungal keratitis. Confocal microscopy has also been developed in the recent time, and they are used very effectively for diagnosis of infective keratitis. For patients that have reasons to suspect systemic diseases like rheumatoid arthritis and other related non-inflammatory causes of corneal ulcers, we may have to extend our investigations beyond corneal scraping for microscopy and also for culture. Away from the general baseline investigations of full blood count, ESL, fasting blood sugar, and retroviral screening, there may be a need for a chest X-ray. There may also be a need for some other more ancillary tests, like the angiotensin converting enzyme assays, ANCA, and rheumatoid factor. They're also very important agents. Like we said, for OCT, it gives us a deep image, a more concise image of the cornea, giving us detailed analysis, pictorial form of the corneal layers. This is a typical OCT image showing radial keratoneuritis in acanthamoeba, keratitis. So we can see the hyper, echoic level of in the cornea stroma. This also is another form. Here is more marked and can be seen more. Away from OCT, for confocal, it also shows us filamentous keratitis, and you can see the fungal hyphae well marked. However, the use of these newer tools for diagnosis, gives a lot of challenge, particularly in terms of the cost to set up this diagnostics tool. Then also the expertise of whoever will be using it for diagnosis. This is also images of hyperechoic cysts depicting acanthamoeba, well outlined. Direct PCR assay is a rapid diagnostic technique that is very evolving with high sensitivity and specificity for infectious keratitis. And it is expected to have an impact on the diagnosis and treatment of infectious keratitis in future. In fact, in most of the state-of-the-art centers now, PCR is being done more regularly as a diagnostic tool for infective keratitis. It has been known to be used to diagnose virtually all forms, whether bacterial, fungal, or acanthamoeba. Confocal also has an attractive advantage of not being invasive, and it has come a long way as a clinical diagnostic tool for keratitis. And it has been used to diagnose keratitis caused by fungi and acanthamoeba. In conclusion, we have tried to look at the burden of the disease that is with us and the challenges and gray areas that corneal ulcers pose to us as clinicians, and the need for us to adequately, diagnose such diseases. Our take home, in conclusion, is such that, particularly in the developing countries, for diagnosis, equipping of our labs with both personnel and with the appropriate tools and reagents needed to enhance, diagnosis. The burden of the disease is still with us, like I said, and we all know that corneal ulcers, and its consequences, which is blindness, is something that can be preventable with adequate and prompt diagnosis, and treatment. And we know that we need to improve on the detailed history and clinical signs that we observe on patients. That cannot be overemphasized. By and large, a paradigm shift is needed for us to move away from empirical, treatment to the gold standard of practice in terms of management of corneal ulcers. Thank you. We will now entertain questions. We will now entertain questions. There is a question here that says, I need more clarification, the differences between infiltrates and abscess. For infiltrates, these are these are materials as a result of the leukocytes that get into the ulcer zone trying to cope the ulceration. So they end up as dead leukocytes with a lot of materials following the degradation of either of the organisms or of the tissues, the stromal tissues that are around the ulcer area. In abscess, they are very distinct. Abscess basically is pus accumulation, and most of the time there may be an intact epithelium, covering it, just as you have in any other part of the human body. So these are basic differences between infiltrates and abscess. Another question says, what we mean by marginal improvement for ulcers that present to us, and they come in with specific signs and symptoms, either redness, pain. By the time you observe the ulcer area, you take the size, you see the amount of infiltrates that it has accumulated, the amount of edema, around it. Where there is appropriate, an efficacious treatment, you're supposed to see a regression in all these signs and symptoms. However, if the appropriate response to the treatment is not very commensurate with the treatment that has been given, the edema particularly, they're supposed to come down, the infiltrate are supposed to regress, the redness, accompanying redness and pain, you may now begin to say, oh, what are we dealing with? Sometimes with the use of anesthetic agents, with the use of analgesic agents, some symptoms may alleviate. And so 2 or 3 days after, a week after, you are not too sure whether you are winning that battle in terms of regression of that very ulcer. So when there is no outright and consistent sign of regression of the ulcer, then it looks marginal in that regard. Now, marginal improvement may not necessarily be a sign of failure. It may not be a sign of failure. We do know that many a times for edema, it may not regress immediately. In fact, it may even increase. The area of the ulcer may also increase, depending. But that may not be a sign of failure in treatment, but at least it will alert, one needs to be alert to be sure that it is not going to lead to a failure, or it's not going to end up in failure. Another question is, when will you consider your empirical treatment as ineffective? All right, for us to consider our empirical treatment as ineffective is when there is an outright worsening of the ulcer. Certainly you can know that the empirical treatment is not working, or it's not effective. The ulcer that you examine today, the size is 0.5 millimeter in diameter, and by the third, fourth day, the ulcer size have increased to 1 millimeter in diameter to 1.5 millimeter in diameter. You know that certainly this is a worsening situation. So you consider that treatment is ineffective. With another question says, with all the atypical presentations of acanthamoeba, can we assume that acanthamoeba is coexisting with organisms such as bacteria and virus? It could. And on the other hand, it may be solitary. We know of several situations where patients were diagnosed with herpes simplex keratitis, and with the treatment for herpes simplex, there was no improvement. Ulcers were worsening, and only with further evaluation and investigations, then a concurrent organism of acanthamoeba, was isolated. So it's very possible. It's very possible. Now, I don't know whether there are more questions. Okay, another question says, please, what is your advice on when to consider systemic medication? Well, we do know that for corneal ulcers, topical routes of medication, I'm hoping that we will have some other time to consider topic on treatment for ulcers. But be as the question comes, the room for systemic medication is when the ulcer seems to have gone beyond the cornea mid-periphery. It has gone into the periphery, because we know that medications via systemic route do not get to the cornea adequately because of the avascular nature of the cornea. Howbeit, when there are anterior chamber reactions, when there are evidence of hyperemias, that is well way off, and we know that the medication given systemically can get to the point of the infection, then of course we give systemic medication. In fact, for ulcers also that are already vascularized, because of the vascularization, systemic medication may be very imperative or advantageous in such condition. For ulcers that have presented with perforation, somebody is asking that will you still consider scraping? No, I will be very cautious in scraping because you might disseminate the organisms further. might worsen the degree and the state of the perforation, and introduce organisms intraocularly, given the risk of endophthalmitis and the likes. So for such, you may want to avoid direct scraping. Another question says, what are the features of a healed corneal ulcer? The features of a healed corneal ulcers, like we said, depending on the degree of the ulceration. If the ulceration has gone beyond the Bowman's and have gone into the stromal and deep stroma, you could have a corneal scar forming, and there are different degrees and levels of corneal scar, from leucoma, to a macular scar, to a nebular scar, depending on the degree of affectation of the stroma. So scar formation is one feature of a healed ulcer. Then some ulcers we heal without sequelae, completely. Particularly, if there are ulcers just affecting the epithelial layer, not reaching the Bowman's. Such are the features. All right. Any other question? It appears that's the last question. All right. So I want to thank you all for listening. And like I said, we hope that we'll be able to get some other time and we'll consider treatment in-depthly. Okay. There's another question here. When scraping, where in particular do you scrape? Yes, we said you consider taking scraping to include the edges of the ulcer. You consider scraping to include the edges of the ulcer. Then another question is, when do you do a biopsy? For biopsies, when most of the investigative modalities as outlined in microscopy and in culture are not giving adequate information, and the ulcer is still persisting, there may be a need to take a biopsy. You will even be dealing with a neoplastic condition in such a situation. So a biopsy for histopathology analysis will become very imperative. All right. I'm not sure there's another question. All right, do we say thank you very much?